morning, everyone. So it is dot at 10:30, and we start this National Symposium on Retina. And I have with me a lot of eminent persons to, be the chairpersons in this session, which include Dr. Mallika is there, Dr. Sangeet, Dr. Pramod Bende, Sangeet, and Dr. Rajiv Raman. So in this symposium, we have 5-6 topics also only. And these topics, I am happy that they are, all of them are practical relevance. I think all of us see them virtually every day. People who practice only retina, they see them every day. So aim is to seek clarifications on this topic and the way they are being managed now, and where are we standing in their understanding of the disease. So we'll begin with the first topic, that is central serous retinopathy. And we have with us Dr. Ajay Arora. You see, we thought CSR, we know everything, but of late, with the coming up of the pachychoroid spectrum, although it's not very well still understood what is pachychoroid. We know the definition of pachychoroid, but newer and newer entities are being added into it. Pachy means thick, and we have to see that choriocapillaries and the smaller vessels, they get attenuated, and bigger vessels, they become more prominent. And CSR today is likened to be more of a choroidal disease only. And a lot of things have changed in the approach to a patient with CSR. So we have with us Dr. Ajay, who has done a lot of work, and he has personal experiences in especially center involving leak in CSR. And he will tell us where we are today. I hope Ajay will focus on the topic itself, that where are we today, rather than giving the entire history of CSR. Where are we today? Ajay.
Thank you, sir, and all the dignitaries on the dais, all the people who have come to attend this session early in the morning. Can I have my slides? Yes. So I'll be talking on CSR where we are today, since there's a lot of general ophthalmology sitting, so I thought I'll just brush up. CSR basically is an idiopathic disorder. There's a serious detachment of the neurosensory retina with alterations in atrophy of the retinal pigment epithelium. There's a thickening and dysfunction of the choroid, as Dr. Lalit said about the pachychoroid. Patient may present to you with blurred vision, metamorphopsia, micropsia, reduced contrast sensitivity, and scotoma. They are usually young and middle-aged males with type A personality, under stress, may be using steroids anywhere in the body, either inhalational or even on the surface, applying steroid creams. And it is commoner in Asians, but if it occurs in blacks, it's more severe. The changes of the choroid, there is a choroidal hyperpermeability, which can be demonstrated in both eyes, even if the CSR manifests in one eye. So there is a relevance to the multimodal imaging, and that is where the importance of pachychoroid comes in. You can have fibrinous exudation and the neurosensory detachment. You can have enlarged blood vessels. And you can have hypofluorescence or fundus autofluorescence. That is because of the fluid present there. You can have leak, which can present in, which can be unifocal, multifocal, and in various forms, which we have all learnt in the past. And this is how it looks like after treatment, and you can have RP atrophy because of the treatment itself. So there is a stepwise approach to the management of CSR. All patients who come to you initial period of 3 to 6 months, you are going to observe them, talk to the patients, reduce the stress, stop all steroids. Prompt laser treatment at this stage does not improve visual outcome and may actually induce a choroidal neovascular membrane secondary. We have to manage the risk factors like smoking. We have to counsel the patient well. But then we have numerous treatments available. These could be divided into medications or lasers. Medications can be systemic or intravitreal, and lasers can be thermal, PDT, and a subthreshold micropulse. I have got experience on the micropulse laser treatment, so my talk would be to some extent stressed by that. So this is a small series which we had done some years back of observation of central serous retinopathy, which are acute CSR. You observe them, follow them up for adequate period of time, and they reasonably do well. Now it's a list of systemic medications. I will not read out through the details, but these have all been tried There are numerous publications on each one of them, but one which is of some relevance is the mineralocorticoid receptor antagonist, particularly spironolactone and eplerenone. Both reduce the subretinal fluid and the choroidal thickness, but the visual acuity change is not statistically significant. They are both almost equally effective, but spironolactone has got certain side effects like hyperkalemia, gynecomastia, reduced libido, and menstrual changes. Now, intravitreal injections of VEGF have been given by people because VEGF apparently is given for all indications, including pterygium. But there is poor evidence of utility. It is only indicated in presence of a secondary CNVM. In patients who do have a secondary CNVM related to CSR would require about 4 to 5 intravitreal injections over the period of 1.5 years, as compared to about 12 to 13 injections in cases of age-related macular degeneration. We have been all doing thermal lasers, which has been done with a predominantly green laser, but we have now Navelas laser. If for an extra foveal leak, you could use a thermal laser. Coming to PDT, we have had a full dose PDT, half dose PDT, and half fluence PDT. Basically, it's an intravenous injection of a photosensitive dye, which is waterpoffin. And I will not go through the dosages, which we know there's an activation of a laser at 689 nanometers, which is used for 83 seconds, and we've been doing it for a long, long time. Unfortunately, PDT is no longer available in the country. So it's difficult to have an access to it, but we should know about it, know about the half dose and half fluence PDT. And PDT is supposed to work because of vascular remodeling of the choroid and a decreased choroidal volume, permeability, and leakage of the fluid. It's been shown by a collaborative study published in ophthalmology, which was done by the Macular Society, which was a retrospective series of patients, of 237 patients, which basically showed that the clinical response to PDT treatment was not affected by the fluence setting. That means whether you do a half fluence or the full fluence, it did not matter. It did not matter on the type of the leakage of fluids in angiography, on corticosteroid exposure. So whether the patient was on or off corticosteroid, it did not matter. The visual gain was associated with a worse initial visual acuity. This is just an example of a patient who underwent PDT and responded well. What is important to understand that the post-PDT, the rate of recurrence was reduced to about 10% compared to no treatment. The recurrence rate was about 30 to 50%. PDT is equally efficacious, as I said, whether patient is on or off steroid, and continuation of corticosteroid at the time of PDT for some significant indication did not preclude a favorable response to PDT. Coming to the micropulse laser, this is a landmark study which was done by, which was a seminal study which was done long time back, which showed that the burn duration equal to damage. So if I reduce the burn duration, I could potentially affect only the retinal pigment epithelium. You can see here that as we reduce the duration of the burn, so initially we can detect it on the fluorescein angiography, then we may not detect it on the fluorescein angiography, and a micropulse technology basically breaks up a continuous wave into beams which are active for the shorter duration of time. Like here, this for 2 milliseconds, so it's a 5% duty cycle. So it is an on and off time. So the off time allows the tissues to recover. This is an example of a micropulse laser where you cannot actually demonstrate changes even in the OCT. Now there are 3 wavelengths available with the micropulse laser: a green wavelength 532, 577, which I have an experience of, and worldwide this is the preferred wavelength, and 810 nanometers. Now the reason which people disbelieve micropulse is they say, I don't see anything, so how do I know it works? So this was an immunohistochemistry which was done by a Japanese group, which showed that if you do a conventional laser and you produce a burn like this, it is the area around the burn where you have production of heat shock proteins. So if you have a micropulse laser, this entire area becomes an area where the heat shock proteins are documented, and you can see here they documented the production of heat shock proteins. You can see this change happening. So this showed that micropulse laser, when it is used, it does produce changes which are working at a tissue level, at a cellular level, at an intracellular level. And when a micropulse laser is given, there's production of an anti-angiogenic tissue restorative factor, and therefore it is known as a laser which is non-traumatic to the retina. It was after numerous studies which was found that a low intensity, high density laser is what is used. And this is one of the picture we had taken just to show you that how a Pascal laser in a micropulse works. It goes like this, comes down, goes like that, comes down, and you can do a 7 by 7, 5 by 5, or 6 by 6 squares. Here are some examples. This is a chronic CSR patient, 58 years old male who had CSR. You can find a multifocal leakage for about 14 months, treated with micropulse, responded very well. Another patient, a 63 years old male, 18 months chronic CSR. Again, this patient had been treated with micropulse, responded well. Here was a patient who was a dentist. He came to me after having CSR in both eyes for last 5 years. And his only complaint, he was not worried about 6 by 9 vision, but he was worried about metamorphopsia. He was an epineuron when he came to us. We stopped epineuron. We did an OCT angio, and we found that in his right eye, he had features of a secondary synovium. You can have a flat PED with an irregular RP surface, a notched PED here, and a pachychoroid. You can find large blood vessels. In the left eye, he had a CSR with small PED, but no evidence of a pachyneovasculopathy. So this was when we could demonstrate a pachyneovasculopathy. We went ahead and gave an ILIA for this patient. This was in 2019. The patient responded. And in the left eye, I treated the patient with micropulse laser. Immediately 3 weeks after the laser treatment, actually his neurosensory detachment worsened, but over a period of 6 weeks it flattened off. So when a patient comes to you after a micropulse laser treatment, even if the neurosensory detachment worsens during the initial 3 weeks, it does not matter because eventually it will recover, and I do not retreat the patients at least for 2 to 3 months. This is a patient who is an ophthalmology resident, who had come to me with a paracentral scotoma. So we treated him in his left eye, and now he has come over a period of last 1.5 years. And you can see that he has, whenever he develops a blurred vision, which is extrafoveal area, he notices it. He's an ophthalmology resident, and he's doing well. Over the period of last 3 years, I've given him 3 treatments, and he's doing well. So this was a study which was comparison of micropulse laser with PDT. It showed that both are effective. This was a study done in India from NN, which again showed that micropulse laser yellow wavelength was effective in the treatment of chronic CSR. And then on a low fluence photodynamic therapy, when we compared it with a sub-threshold micropulse laser, it showed that at the end of 1 year, micropulse laser reduced the subretinal fluid more than the PDT. We have to also remember the masquerades of CSR. So in conclusion, let me say that acute CSR, you must observe, stop the steroids, reduce stress, and treat other complications like patients should stop smoking, hypertension, chronic CSR. I feel micropulse laser therapy, especially for the central leaks, in the 20 of the 19 eyes which we have evaluated till now, we have treated more. They have responded in our series completely. Can be repeated after 2 to 3 months. It is a safe treatment, causes no damage to the neurosensory retina. It is much cheaper than PDT and is very relevant for India. There is no dye injection. Octa can help us in detecting pachychoroid and the secondary synovium, and this allows us for an appropriate treatment. I think micropulse laser is underutilized in our country. We can utilize it in more number of situations, and I think it is going to be effective. Thank you.
Thanks, Ajay. So, where are we today?
So the protocol is very clear. If we have an
so let me ask 2-3 pointed questions because time is less and we have to summarize also. I think you have summarized it very well. acute CSR don't do much, masterly inactivity.
Correct.
You said reduce stress, that may or may not be possible depending on the, it's easier to say reduce stress. So
We have to counsel the patient.
Yeah, so counseling is easier said than implemented. And smoking and all that's okay, hypertension is also okay. But stress reduction is not so easy in today's world. Then coming to chronic CSR, if it's laserable,
So most important, they should stop steroids. We find patients that's very
well
important.
understood, So in India, you have to also consider the role of these homeopathic and Ayurvedic medications and skin creams and all these things which you never know their constituents. And as far as chronic CSR, laserable, go ahead and do routine laser.
Extrafoveal,
If it is non-laserable, that means it is in central part leakage is there. At least for me, there is no role of, giving anti-VEGF injections. People still give anti-VEGF unless and until you have documented CNVM documented by OCTA. My question was that today, where are we central leak chronic CSR choice? We will have, before I ask you, let's have from the panel, Gopal, are you here? Central leak chronic CSR, what is your choice? One word answer. PDT not available now.
Yeah,
Issue is this.
PDT is not available, so I would consider, I would do a fluorescent definitely, look for any leak, but then...
No, central leak, I'm telling you, central leak is there.
Okay.
Central leak, subfoveal leak.
Eplerenone or injection. I think intravitreal injections or eplerenone.
So unless it's a pachy-CNV, eplerenone.
Eplerenone. Sangeet?
So I'll just observe.
Observe.
Yeah. And
Rajiv?
just explain.
Eplerenone, and
Yeah.
if there is a CNVM on OCTA, which you
CNVM
said,
is not, yeah.
then injection.
Injection.
So micropulse or injection?
Okay. Observation.
Earlier I used to, but now I shifted to eplerenone. First time, naive patient, I would definitely like to start with that.
Eplerenone, sir.
Eplerenone. Micropulse. So, I think it's 25% micropulse and 70% eplerenone.
So you have to ask everybody
So
this
now
question.
therefore I'm coming to the master.
Do they have micropulse with them available? If they don't have, they will not do it.
I'm coming to that. So, people who have micropulse and they're not using it for this.
Yes, sir. I'm one of the example. Of
Yeah.
course, we use it in So I just want to ask you the question: what you consider the height of the SRF? If it is too tall, if it is more than 400, 500 micron, we have very suboptimal responses we have seen. And the cases which you showed, sir, they were slightly of the lesser size of the height of the SRF was slightly slower. So what do you think is the cutoff point for doing micropulse in these cases?
So my cutoff is about 450 microns, but I've done it and more this thing. And see, the problem.
So you do it only at 5% of duty cycle. You don't increase the duty cycle.
With the macula in CSR. In my series, we have had almost about 98% success rate in CSR.
So in any case, Ajay, micropulse is not a cure for CSR. It is generally required to be repeated also.
Yes, sir.
And I believe, I was talking to Pramod also, maybe 810 maybe, because it's a choroidal disease now, 810 may be more useful and preferable if you're talking about reducing damage to the retina. And I presume and feel that TTT, what we used to do way back, as TTT is 810, could be also an alternate for that.
The only problem with TTT, sir, it is a damaging laser. Micropulse is not damaging laser.
Yeah. So as of today, anybody from the audience has any comment about only one point, chronic CSR, central leak, active?
I had the question that
no, are you answering this or?
Experience treating central subfoveal leak with micropulse, and what are the results?
That's what he showed actually. He showed there. He showed in this slide.
And what is the rationale of ILIA or injection?
No, ILIA in all anti-VEGFs in pure pachychoroid in CSR without OCTA or FA documented CNVM, I don't think so anybody uses. CSR, pure CSR is not a VEGF-related disease. But if it has a component of CNVM based on OCTA or FA, then nobody hesitates to give anti-VEGF. But I am against using anti-VEGF in case it does not have any CNVM. Yes?
So chronic CSR with subfoveal leak, first observe. Second, I think the subthreshold also.
Prabhakar, if you observe, na, patient goes somewhere else.
Yeah. But that subthreshold thing is also just a temporary modification of the underlying pathology, which is pachychoroid in most of these cases. So let us call it just a modifying agent and not a...
Yeah, because we used to have excellent results with PDT, excellent results. In fact, Ajay, you used to show one slide where PDT has been compared with micropulse.
Better thing would be to compare the thickness of the choroid in those patients who have undergone subthreshold laser and who have not undergone. If the pachychoroid levels remain the same, then it is just a chance that your RPE has given way and therefore it has manifested as CSCR.
Okay, let's ask Dr. Andy, suppose you have options for micropulse, you have options for PDT and eplerenone. So what will be your first choice? All these things are available to you.
I've not had good success with the plurineron. I like PDT, and in fact, I don't even wait for it to get to the chronic stage. I think that it, as you've shown, it does reduce the risk of recurrence, and recurrence central serous is a problem, and I think that you get better results if you treat it acutely. So I don't wait any longer.
So there is a study.
Let's conclude this.
Let's conclude this. Ajay, which published in
Ajay, let's conclude this talk by saying, you see, first 2-3 categories are perfectly okay. All of us are bothered. I am not too happy with the statement that chronic CSR suffer will leak. If patient is disturbed, I don't think so. Observation is a good strategy to follow in such situations. And if at all, the bulk of evidence is in favor of either PDT or micropulse. And people who have micropulse, I think they shout from the top that micropulse is effective. And as Anand was saying, it's a disease modulating state. It's not a cure, and we may have to repeat it. And believe me, eplerenone does not have such bad results. As was presented in American Academy, they washed away eplerenone, and that is not true actually. You see, in a lot of personal experiences, eplerenone does work. It may not work forever, but till the time, it may take some time, but personal observation, and I have spoken to a lot of people, it does work in around 60 to 70% patients. If I agree with you, if you have micropulse, that should be the second question. If you have micropulse, then do you use it or not? And I think what Andy said and you said, we take it from you that micropulse in the absence of PDT, I think that should be the first choice.
Thank you, sir.
Thank you. I think.
So one drug that you should ask for in CSR cases is sildenafil use, which we don't ask.
Yeah.
So there are actually there are certain biomarkers which indicate which CSR acute may go into chronicity.
So let's move ahead, Ajay, because we can go ahead. So now we have, Pramod, you want to add anything to whatever has been discussed in CSR? Mike?
Yeah, just limited experience with eplerenone, somehow not very happy, but we cannot predict which case it works, which doesn't work really.
Okay, now we move on to another big question, that is management of PDR without vitreous hemorrhage or TRD, because there has been a real push by the industry to use anti-VEGF agents for all stages of diabetic retinopathy, and there, everything has been DME, there's no doubt, and PDR without hemorrhage. So basically what we wanted out of the laser is still the mainstay, or a combination of both of them, or alone, as a lot of people in the West have started, just to reduce the DRSS severity scale, pushing of anti-VEGF in all the stages of DR. So we have with us Dr. Pramod Bhande, a very, very renowned name in India, from Chennai. He will tell us about PDR without vitreous hemorrhage.
Thank you very much, sir, for having me here. It's a great honor. I am restricting to, as Dr. Lalit Verma said, medical management, and of course macular edema also will be subsequently dealt with Rajiv, so I am just not going to touch macular edema, maybe just a brief running through. So basically, PDR is a vasoproliferative disorder, and when you manage these eyes, you need to have, most important factor comes as a appropriate workup. History, you need to look for duration of diabetes, symptoms, underlying systemic factors, patient, which medication is taking, and particularly history of rapid progression of the disease. Clinical examination, obviously baseline vision. When you look for anti-segment evaluation, look for NVI and NVAs and conventional methods of fundus evaluation. Systemic evaluation is extremely important, particularly duration of diabetes, how well it is controlled, and associated systemic hypertension, renal disease, and cardiac status. Coming to the imaging, and we all know good metabolic control is an integral part of a diabetic management, so fasting and postprandial sugar, HbA1c, serum urea, creatinine, basically again looking at a renal status, hypertensive and lipid profile, and good diabetic management. Coming to the ocular investigation, generally imaging complements the treatment approach to the patient with a PDR. And when you look at it, FFA is one of the most time-tested baseline evaluation to detect subtle new vessels, ischemia, perfusion defects and changes. For obviously new vessels when you have or NVD or NV, you do not need FFA, but with subtle changes we know obviously FFA adds on your decision making, and also helps to guide laser when you are having associated macular edema or when you plan fill-in laser photocoagulation. And when in cases with the asteroid hyalosis, so sometimes visibility is extremely difficult, what FFA gives you excellent view to plan your subsequent treatment. Ultra wide field imaging nowadays helping us a lot. Look at conventional 7 field, and now ultra wide field gives you almost 11.7% of more detection of new vessels, and also almost more detection of new vessels NVEs in a peripheral area and as well ischemic areas. As this is showing, you have a clearance picture having photographed peripheral new vessels and CNP areas, which obviously beyond 7 field and conventional photography would not have helped. Also, it helps us in assessing adequacy of pan-retinal photocoagulation. OCT helps you identifying macular edema. Of course, clinical examination equally important, but subtle edema obviously you can pick up well with OCTs. And also associated morphological changes probably helps you in discussing prognosis with the patient. So it also helps to assess vitreomacular interface, particularly when you look at epiretinal membrane, vitreomacular traction, and then various tractional components, whether PVD is there or not, and that is what OCT helps us. Coming to the OCT angiography, it's a non-invasive technique now more extensively being used, but it's still, I would say, not yet substitute for FFA. So it helps to detect mild perfusion defects, layer-specific perfusion changes, and you have a better understanding of foveal avascular zone, its regularity and pruning of the vessels. It also helps to detect the new vessels at the interface of retina and the vitreous, sometimes which can easily to miss. And of course, last in the investigation armamentarium is your ultrasonography, where you have a media opacity. So ultrasonography helps us to know the status of the retina. Again, posterior hyaloid status, its attachments, associated vitreous membrane, and vitreoschisis. This is just a picture showing a large wide spectrum of what we call as a PDR. So we'll go clinical scenarios one by one. This is a patient with a 63-year-old male, recently diagnosed diabetic, vision is 618, fundus evaluation and FFA shows isolated single NVE. How do you manage? Probably, of course, you again need to assess macula and overall perfusion status. You can, technically it is like a non-high risk PDR, so you can have a close follow-up, and possible options will be, as I said, observation or conventional PRP, targeted laser or intravitreal anti-VEGF. However, we prefer PRP in a certain situation where you assume if there is a poor compliance to follow, if there is advanced diabetic disease in other eye, if there is a poor control of systemic parameters, and if there are wide areas non-perfusion. Targeted laser can be attempted where to ischemic and CNP areas, but the advantage is not to destroy healthy, well-perfused retina, but at the same time, you need to have very close follow-up for fresh new vessels, and sometimes it will be difficult. Intravitreal anti-VEGF monotherapy, yes, it works, but problem is repeated injections, so cost is an issue. There is a need to frequent, careful, lifelong follow-up, which again subsequent studies have shown may not, with sometimes difficult and practical issues, and if there is a failure to follow up, there is a reactivation of neovascularization, even progression to neovascular glaucoma as well. This is another patient with 55-year-old male, diabetic, vision is 6.6 and 6, and what Octa shows is multiple NVEs all around. So probably this is the ideal patient. I would prefer to PRP, which again evidence-based and experience all of us have, though it is partly again supported by DRCR Protocol S. So what Protocol S says is to compare the safety and efficacy of PRP to intravitreal injection of ranibizumab for treatment of PDR. So, and particularly when you look at a 5-year analysis and looking at a loss of follow-up in this population, which is very, very high, PRP probably a potential to complete in 1 or 2 sittings. There is no risk of endophthalmitis and have overall long-term, both are probably equally good. So practical aspect, when you look at it, probably PRP still is better off in our scenario. What are the ideal candidates where probably you would choose anti-VEGF, where you have associated diabetic macular edema, no macular threatening traction, if there is a recurrence of neovascularization after good PRP, and associated partial minimal vitreous hemorrhage which prevent completion of PRP but no visible traction. So high risk PDR, DRS has already proved that PRP reduces the risk of severe visual loss. And when to commence PRP basically is ideal to prefer to start as early as possible, as a delay again can reduce overall final functional outcome. So all of us know high risk criteria. I am not going to go in detail, and ETDRS goes one step ahead, considering that even severe NPDR should be treated with PRP. Now, how you do laser photocoagulation? Generally, these are create a chorioretinal burns of a mild to moderate intensity with a 1 to 1/2 burn width apart, and you extend up to arcade superior inferiorly 1 disc diameter area nasally and probably 2 disc area temporal to the macula, and that's what ideal way of doing PRP. So when you add additional PRP, particularly when there is failure of neovascularization to regress, you need to give 2 to 3 months of time. Generally, that's what we follow. If there is no satisfactory regression, if there is space available, you add on some more laser. You can increase the areas going closer to the temporal side, probably toward the macular area, and generally burns are placed in between previously treated area. So this is a 48-year-old male, had a diabetes, having a loss of vision since 2 months, diabetic since last 5 years, vision was 624, and had a PDR with CMIN. Probably this is the case. Ideally, you can have, though you can try anti-VEGF monotherapy, but all of us would prefer combined anti-VEGF therapy along with PRP. But if there is diabetic macular edema and associated traction, surgery would be the better option. When you deal with a neovascularization, this is the case, having a DOV since last 1 year, vision was 636 in the right eye, left eye was 6 by 7.5, had asymmetric PDR. These are typical eyes where other eye is normal. You need to investigate them thoroughly, particularly dealing with a more like ocular ischemic syndrome. Patient had a right carotid artery stenosis. You need to treat for the same when dealing with this type of patient. I am not going to go in detail with this big chart, but when you deal with NVI and NVA, you have to be really aggressive, which will probably help to reduce neovascularization of angle and iris. And early detection is the key here. Really, both combination of anti-VEGF and aggressive PRP. And sometimes I go one step ahead, doing even anterior retinal cryo as well to when deal with these eyes. So when come to just mild vitreous hemorrhage, is a 50-year-old male, had a loss of vision since 1 week only, non-diabetic last 14 years. He already had a laser done previously. Fundus view was there, no traction, so we decided to wait for a while and then add on PRP to the skip areas, and patient is doing well. The another case with having a vitreous hemorrhage, some view was there, no macular traction, no previous laser. These are the patient, and when have a, obviously you rule out traction, can be followed up closely at couple of 2 to 3 weeks interval, and as we start clearing, you still can add on laser. Probably this can be the case where you even add on anti-VEGF to support it to buy some time, and eventually, but laser probably will be the treatment of choice in this scenario. Coming to cataract combined with a PDR, if you have a retina is visible, is visible, I would prefer to stabilize the diabetic process first and then consider for a cataract surgery. But if there is no view of fundus, you assess the patient on ultrasonography, there is no obvious traction, then probably can go ahead with the cataract surgery and earliest possible opportunity, evaluate the fundus, and then plan your treatment depending on the stage of the diabetic retinopathy. To summarize, PDR is a proliferative vascular retinopathy seen in diabetics. Laser PRP is still a mainstay of treatment for PDR in our scenario. Anti-VEGF can be combined with PRP in eyes with center involving diabetic edema and recurrent neovascularization. Role of anti-VEGF as a monotherapy is still debatable, but in advanced diabetic eyes, pre-surgery intravitreal anti-VEGF helps to minimize intra-bleeding for more complete removal of fibrovascular proliferations. Tractional detachment is the commonest indication for vitrectomy, and early treatment and good metabolic control gives a better final outcome. However, long-term follow-up is essential for these patients. Thank you very much for patient. I would like to acknowledge Dr. Raji Raman, my two fellows, for helping me to create this presentation. Thank you very much.
Excellent, Pramod. I think you have summarized. Any one of the panelists differs from whatever he has said? Any difference of opinion?
In my audit of about 250 patients of proliferative diabetic retinopathy, I had about 12% incidence of bleed within the first 2 months of laser photocoagulation. And so if it is near the arcades, I will consider an injection than a panretinal photocoagulation.
So Gopal, if you consider injection, you do it after the laser or before?
Before the laser.
Before the laser. That is treatment naive patient of PDR. You will start with anti-VEGF injection.
One injection followed by laser.
One injection followed by laser.
Over 2 months, I will complete the laser.
How many days after injection?
Maybe a week.
A week.
If there is no visible traction.
Yeah. Yes, Andy.
So one of the things I like to look for in a patient with proliferative diabetic retinopathy is venous beating. I think venous beating is the most important sign when we look at all the various features within diabetic retinopathy, cottonwool spots, hemorrhages, microaneurysms, ERMA. Venous beating, I think, is one of the most important features. I, therefore, titrate the amount of PRP I do based on the extent of the venous beating. So if a patient has really extensive venous beating, that tells me there's a lot of ischemia, and I'll do a heavier PRP, as you suggested. Whereas if it's an older patient, 60, 70 years old, and they have a couple small fronds of retinal neovascularization, they're bleeding, but they have very minimal venous beating, I'll do a more broadly scattered PRP. So I'll track it that way. And then post-laser, you expect that venous beating to go away over 6 months, a year or so. So if a patient comes back 2 or 3 years later with a recurrent vitreous hemorrhage and the venous beating has gone away completely, I know that vitreous hemorrhage is secondary to traction. It's a mechanical vitreous hemorrhage because the patient developed a PVD, and although we expect PRP to induce regression of the retinal neovascularization and disc neovascularization, there's still some persistent neovascularization, and so it's purely tractional. Whereas if there's persistent venous beating after my PRP, then I know they need more laser also.
So you still depend on laser. You see, you think that bleeding is more indicator of ischemia. Yeah, I think he stressed that. Only thing he was stressing on angiographic CNP areas and other things. But venous bleeding, I think all of us agree on that. The only thing I wanted was that Dr. Gopal said that he may start, only difference, Gopal, I have, whatever you said was that not in any PDR, but only where the fronts are on the posterior pole. You see, sometimes you have situation where if you have front right on the arcade, where laser
in which a PRP can actually cause a premacular bleed very rapidly, and very unhappy patient also.
So anybody else who starts the management of PDR with injection?
No, certainly I would give an injection, but with the first sitting of PRP at the same time, which would take, the injection would take care of the...
So you are dependent more on laser, not on injection?
Absolutely. The dependence is only on laser. The anti-VEGF is only to prevent an immediate bleed, as well as maybe the DME worsening or starting.
Nobody can titrate whether this will bleed immediately or not. You see, nobody can tell, there's no parameter.
If we do not want the risk of bleeding for whatever reason.
You see, for all these decades, we have been managing, and for not 1 decade, 2 decades and decades. I think all of us have good photographs to show that it's a excellent treatment. Laser is still the gold standard. And as Andy was saying, if there is venous bleeding, you add more laser rather than pushing this short of anti-VEGF. Anti-VEGF means repetitive, and you need to follow whether patient will be compliant enough to follow or not. That was the issue. And with the industry pushing us to, keep injecting, that was the issue. Yes,
we should keep in our mind that PRP has some the visual field effect that will result in. So initially, it is better to start with this anti-VEGF if there is some amount of edema is there.
No, edema, I think there are some things which are very clear. That with edema, everybody, DME, I don't think so anybody, that is very clear. PDR with HRC, very clear that tight PRP is the answer. But it is those gray zones where, people keep injecting. I was bothered for that. PDR with DME, I don't think so anybody in the panel will have any difference that we start with injections and other things and add laser. But it is the pure PDR. I think Pramod brought out very, very clearly. Therefore, I asked first question was anybody differs with him or not?
Just in my opinion, I don't think so, sir. Laser is still the gold standard, it holds good, but only in select cases like when there is a pilot,
1, 2, 3.
if he's a pilot, if he's a pilot, if he's in the military, in those cases, the field of view definitely becomes important. So,
the question is not about continuing the injections with protocol S, but the thing is about one injection followed by PRP.
Yeah, what do you say?
No, the question is not about continuing the injections. That nobody is going to do here, because we will all do pan-retinal photocoagulation.
Very good, very good.
The question is,
another very good point.
Another
very good point. I think Mallika also was stressing, and Gopal has said, in PDR, rapid injection may not be required. It's just one maybe injection just to facilitate or to reduce the chance of bleeding. That's what Mallika was hinting.
Exactly.
That is
yes. Last, Rajiv.
Just to add that the thing that field restriction will be there. It also happens with anti-VEGF. So at 5 years follow-up, protocol has actually found that the field effects are same, because there are though the ischemia still continues.
So what will you tell your pilot next time? Injection or laser?
Of course, I would still prefer laser in doing that. But in those cases, if there is only a focal NVE, so I think, I would still like to do a targeted laser. I don't want to be too aggressive on these patients,
no, I think
unless they have an NVD,
okay.
unless they have a neovascularization.
That the laser is the mainstay. Injections have an adjunct value only. Adjunct value means facilitation of this thing, or recurrence patients, or at a very sensitive area you have fronts.
I have a point, like if the DME is not there and the patient is having PDR 2-3 neovascularization, so give single dose of anti-VEGF followed by PRP so that you can titrate the amount of PRP to decrease the visual field effect.
Boral, I still wish that starting with injection may not be a wise option. You see, starting with the yes, Ajay, you want to make a comment?
I have a small question. Does the panel differentiate between a flat NB versus an elevated NB? Because that is, to me, important if I wish to decide whether I want to give an intravitreal injection or not. Second, this is just another spin I want to add, that we have been following a few cases. It's not a large series. We have done a targeted laser and added a micropulse PRP in these cases just for the sake, and it is working.
Ajay, everything is not micropulse. Everything you titled. Okay, so let me ask Pramod Bende about this.
Don't have much experience with micro, though we have.
No, his question difference between elevated and flat.
So actually, because elevated obviously again indicates there's some amount of PVD is there. Basically what happened, flat one, probably use, but I think either way I would prefer, given option, is my first statement is always laser photocoagulation. But what happened when having a flat proliferation, you have that indicates no PVD. I would prefer, definitely I tell fellows that have a light one always. Because the problem there is sometimes you nail down, if a heavy one you nail down posterior hyaloid. Subsequently when they bleed and when you take them for surgery, PVD induction can be very, very traumatic, difficult and traumatic also for the eye.
Okay, we'll have last comment from Sangeet.
Sir, it's not a comment, just a situation that is commonly present is sometimes we have those multiple extensive fronts just bordering the macula and not involving the macula. The vision is 6'9", 6'6".
Yeah.
And when you do laser, suddenly the traction happens and the retina gets detached. What is the...
Correct.
So one last question.
So I think, let's...
Yeah.
So one last question. If a multi-millionaire person is coming to you...
Multi-millionaire?
And he's ready to spend n numbers of injection in the next 10 years, what will be your choice?
Answer is still gold standard. I don't think so we change with pilot and multi-millionaire. That has no role to play. You see, ultimately we have to stabilize the eye, not the dollars and all. Don't worry about that. I don't think so. You see, it is relevant. Even owner of Geo Center, Mukesh Ambani comes. My session will be laser, and laser.
So one point. One point last. If you have, I have seen several times, if you have missed PDR before cataract surgery, then after cataract surgery, you may get a situation like endophthalmitis. And we've even proceeded with vitrectomy to find that it was actually a hemorrhage and it was NVG. So NVI can present immediate post-operative cataract surgery as inflammation, severe inflammation.
Yeah.
So look at the iris. If there are new vessels, then inject anti-VEGF, not antibiotics.
Okay, we'll take this question afterwards, after Rajiv. Rajiv will save 1 or 2 minutes for us. Yeah.
Sure. Thank you so much. Thank you, sir. Can you put my slides on?
Rajiv, we'll just be focusing on center involving DME.
Perfectly.
And we'll not talk about general.
Correct. So, next couple of minutes, I'll be sharing the center involving diabetic macular edema algorithms for treatment. So there are some guiding principles in treating center involving diabetic macular edema. The first thing is you tend to classify whether it is center involving or non-center involving. Usually you use the help of a OCT to do that. Glycemic control, control of blood pressure, serum lipids, anemia, they are definitely very crucial whenever you are managing center involving DME. Anti-VEGFs are the first line treatment for CI-DME cases. We switch anti-VEGF or switch to laser or switch to steroid if it is a partial or a non-responder. OCT and vision are the key tests for determining the initial treatment choice as well as the follow-up. You want to do these things. And in case there is a vitromacular traction and in select cases of a non-responding DME, vitrectomy does have a role. So let's see how this algorithm we do. So if first thing you classify whether it is non-center or center. Non-center things are pretty clear, observe or do laser. And if it is center involving, if it's good vision, you tend to observe. That's what the newer protocol, the protocol V has taught us, that observation does fairly equally good as compared to anti-VEGF. And if vision is low, you start with anti-VEGF injections. And after a couple of injections, you start looking at whether it is a good responder, it is an intermediate response or a poor response. That response is based on OCT and based on the vision. And if you see less improvement and it is a good responder, you continue with anti-VEGF. If it is not a very good one, there is a partial response, you still continue. You know that you will need a couple of more injections. But if it is a very poor responder or non-responder, after 2 to 3 injections, you tend to switch. And switching, you have a choice to switch to a different anti-VEGF or you have a choice to switch to a steroid. Now, many times, though this algorithm is the one which we follow, all of us, but sometimes related to the patient factors, the treatment decision may change. Like if a patient has got a history of a cerebrovascular accident event within last 3 months, you tend to avoid anti-VEGF. You consider steroids. You can still consider laser if there is a single, if you see those cercinates, you know there are focal leaks, you can still consider laser in these cases. If it's a pregnancy, if it is a milder diabetic macular edema early in the pregnancy, you can watch. However, if it is increasing, vision is deteriorating, or if it's severe, you can still consider laser. Steroid is questionable, but though people have demonstrated early pregnancy, even intravitreal steroid causing teratogenicity like the oral steroids, but still it is relatively safe, but definitely no anti-VEGF. Late in the pregnancy, if they come, prefer to wait, because macular edema tend to improve after delivery. But anytime during pregnancy, if there is PDR, it needs laser. If a patient is of a poor compliance, you know after 1 or 2 injections he is not coming regularly, that's again something you can think of considering laser or steroids. If a patient is having a chronic kidney disease and you have started the treatment with anti-VEGF, and on treatment you see that his eGFR, estimated GFR is worsening, you can consider skipping the injection to the next visit, or you can think of switching to a steroid, because more recently there are evidences that it affects, especially when there is the renal parameters are deteriorating, not a good idea to continue anti-VEGF. There are several eye-related factors also which affect your algorithm. So if it's a vitrectomized eye with a DME, we have shown now very recently that in early post, no need to be very aggressive treating these eyes. Majority of them, even without giving any anti-VEGF or steroid, in first 5-6 months the edema goes away. So this was actually a multicentric study which we had done comparing comparing the anti-VEGF steroid and observation, and we found that post-vitrectomy diabetic macular edema the visual outcome in observation is not as bad as anti-VEGF or steroid. However, if it is a late DME, definitely steroids are having a little more edge because they remain for a little longer time. Anti-VEGF also works pretty well, but you need more injections, more frequency of injections are needed. DME with PDR, we had discussed anti-VEGF along with PRP or a deferred PRP, both options are there. And if it's a pseudophakic eye with DME, it's important to differentiate whether you are dealing with a pseudophakic macular edema or it's a diabetic macular edema or it's a combined type, both components are there. And you can consider steroids if it has reached a plateau and there is persistent intraretinal fluid. Though again in these cases it's not like anti-VEGF cannot be given, but we do know with all the studies that steroid acts equally well as anti-VEGFs. There are some disease-related factors too. So if you see some plaque of hard exudate, these are the cases you want to control dyslipidemia. You want to, again, steroids have shown a little better effect, and lipid-lowering drugs have got an adjuvant role. So you can start on them. Definitely it works well. We also know with clinical trials that people with poor vision and a thicker retina, probably intravitreal ranibizumab and intravitreal aflibercept are better as compared to bevacizumab. The ones with vitreoretinal surface abnormalities, we know that they show a poor response. They have more recalcitrant DME. They don't respond very well to anti-VEGF. You have to tell from starting this patient will need more injections. We can also consider giving steroids. However, if there is a frank vitreomacular traction, these are the cases vitrectomy definitely is important. And not only these factors, but the algorithm also changes sometimes when you assess the treatment response. And if you see a poor response, poor systemic control, you want to have an appropriate referral. If you tend to identify the best response on history or document, and when there is a poor response, you try to use the same drug again. If it's a chronic diabetic macular edema more than 6 months, again, there is some thought that you can think of using steroids. And if you have history of some of the drugs which cause macular edema, more important like thiazolidinediones, niacin, prostaglandin analogs, fingolimid, again it has come back because of renal cell carcinoma, people using it. You need to stop these drugs, have a follow-up, and then decide on treatment. So if a patient is on this anti-VEGF pathway, you tend to review after 3 to 6 months and see that whether you had inadequate frequency of visits or injections and you see a suboptimal response, or even with inadequate visits you have a good response. So if there is suboptimal response, you counsel the patient, educate him that can he attend more frequent visits or he cannot. If he can, you continue anti-VEGFs. If he cannot, you switch to steroids. And if he is getting adequate response or if he had adequate frequency of injections and you see a good response, you still continue anti-VEGF and monitor. And if there is suboptimal response, you can switch to steroid or switch to any other anti-VEGFs. So the success of treatment in CIDME is not only giving injections, but more important is good control of systemic factors, good compliance to follow-up, and good compliance to treatment. And this you can understand very well if you understand the patient's journey. The patient journey is a very tedious journey. He has the initial phases where it's the diagnosis and he thinks that it is the bad luck, he got diabetic macular edema. Then there is this first injection fear. Then there is this, the machine, the assembly line of machines where he's continuously getting injections. And finally, there is a burnout both for caregiver and for the patient. And at some stage, if the things get controlled, his systemic control is good, the eye is responding well, the vision improves, the quality of life improves, and if not, the things deteriorate. The good thing about diabetic macular edema is it never causes legal blindness. Legal blindness is blindness is less than 3/60, hardly you get it with diabetic macular edema. PDR can cause this. Thank you very much.
Do we have any question from the house before we ask the panelist? Yes, you had some question.
Hello.
Yeah.
It's not the question, but my experience about the anti-VEGFs in PDR cases as well as DME. To start with, I will always suggest to give the injection and then go for the PRP. That works very well because of the onset of the action of any treatment modality. The anti-VEGFs works within 48 hours, so we know that. We always tell that it is 100 times potent and faster than the lasers. Lasers start working after 2 months or after 12 weeks. We have noted several patients, by the time the patient comes for third PRP, there is a bleed. Then how to answer it? We convince ourselves and patient that we have done at least 2 sittings and that was a good thing. But we forget that we would have given the injection in the first go itself. That is one thing. And in any process, there is an induction thing. If it is taught in the preliminary stage, if the patient or something is known forever, if you start with the injection, the patient throughout the life knows that there is certain thing like injection, it has to be taken and as and when advised. That's
okay. Okay. Coming to Rajiv's talk, Atul, any difference?
No, sir. Same thing.
Anybody? Any difference? Only thing I found was your talk was slightly more weighted towards steroids.
Sir, both are there.
Yeah.
Definitely first slide is anti-VEGF, but there are some indications where you tend to think towards steroid. Again,
so what is your threshold of switch? 3 injections, 6 injections, Bristler says 6, somebody says...
No. Even after 1 I have shifted. It's not
after
like if there is worsening of diabetic macular edema, I will first...
Andy, your threshold of switching?
Probably 6.
6. So here, most of us.
Sir, with the biomarkers now available, I think sometimes we even go in phakic patients with the large neurosensory detachments, you can directly go with the steroids because anti-VEGFs sometimes they don't, even the first 3 or 4 injections don't work in those cases. And the visual recovery is better with one single steroid
so can
injection.
as you said, I also felt that there are some indications which you mentioned, such as the presence, presence of exudates, you said you would tilt towards steroid, but I haven't found that difference and I haven't found much evidence in literature that exudates respond better to steroid. Second, also in post-vitrectomy eyes, you mentioned that steroid lasts longer, but there are studies which have shown that aflibercept lasts as long as steroid. So I would still prefer. Third is, if you had mentioned that if follow-up is not possible, then you would prefer steroids. But there again, the raised IOP is a problem. So again, that requires follow-up. So in fact, when a patient is not able to follow up, I would be wary of giving steroid. And I haven't found any difference in the duration of efficacy between steroid and a long-acting drug like aflibercept. So these were the points I wanted to make.
So I think time is not on our side. We will request Andy to, he is a guest speaker for us. We have to give him 10 minutes to speak on necrotizing retinitis. And meanwhile, we will keep chatting. So, threshold, as I was saying.
Sir, let me one point.
Yes,
like what is the role of focal laser after injecting the anti-VEGF?
Yeah, by and large, I think most of our patients, we repeat angiography after a couple of injections, and I, for one, more than 50, maybe 70% patients do receive focal laser. Yeah, it's not that I keep injecting.
Continuing the same anti-VEGF.
No,
I
add
kind of
yes,
focal laser.
Yes.
That will prevent the recurrence.
I have one question before Dr. Andy sets up his screen to Dr. Rajiv. Sir, when you said about the post-vitrectomized eyes, when you have the DMEs, so rather than directly jumping into the Ozurdex or anti-VEGF, can we try with the posterior subtenon injection? And sometimes it works. Rather than being too aggressive and going inside the eye again.
I think Ajay will get up and he'll talk about suprachoroidal injection. Yeah, I will come to Ajay. But the thing is, what he's wanting to know about the apart from intravitreal other routes like suprachoroidal or
especially in the post-vitrectomized eyes.
Yeah.
Definitely, there is a role, and I think Dr. Ajay yesterday showed some beautiful videos.
No, what is your first choice?
Well, first choice is intravitreal. I never.
Ajay, brief answer.
The DRCA.net study which has
choice
shown...
between
DRCA.net study
no,
which
your
has shown
personal choice,
sir.
No DRCR.
Personal
choice.
Personal experience, whatever Dr. Rajiv showed on those cases, many of the poor patients, I use suprachoroidal. I used it in vitrectomized patients. I used it in vitrectomized patients.
So you avoid Ozurdex. You avoid
with
Ozurdex.
silicone filled eye and CME.
Do you avoid Ozurdex and prefer suprachoroidal?
Yeah, I give suprachoroidal.
No, between choice tick mark करना है. Tick mark between Ozurdex and suprachoroidal. दोनों में से एक कौन सा?
So with my hands, suprachoroidal, I use a centrifuged Transilon.
Yes,
It works for 6 months. Ozurdex doesn't work for 6 months.
Okay.
Between intravitreal and suprachoroidal, please make it a point to remember that suprachoroidal will never give you a rise in intraocular pressure to the same extent as intravitreal. Between Ozurdex and suprachoroidal, if the patient can afford, intravitreal Ozurdex.
Okay, I think let's move on and let's hear Dr. Andy. We all know he was introduced during inauguration and the principal guest lectures, and he will talk to us about retinal necrosis.
Thank you, Dr. Varma. Again, it's a pleasure and an honor to be here as your keynote speaker. I'll point out, do I have a pointer here? Maybe not. That this is a rendering of the new eye hospital that we're building in Pittsburgh, $350 million Vision Institute, which will be very exciting when we move in about a year. I've been fascinated by the topic of necrotizing retinitis since I was a resident, and I saw my first patient with, at that time we called BARN, bilateral acute retinal necrosis, for which we had absolutely no idea what caused it. We didn't know if it was a virus or not, and we had no treatment. And I watched a young woman with a couple of children in her 30s go totally no light perception as we just watched in bewilderment as to what was going on. Anyway, if you look at the various conditions that can cause necrotizing retinitis, it's really extensive. You know, we always think of the VZV and HSV as our typical ARN, but there's a lot of things that can look just like it. So we can't just immediately assume a patient has ARN when they present to us. So for example, toxoplasmosis is the most common cause of necrotizing retinitis in America. And when I was in training, we were taught that 97% of cases of necrotizing retinitis from toxo was from recurrence of a congenital lesion. And we would see a pigmented chorioretinal scar with active retinitis on the edge of it, or chorioretinitis on the edge of it. But now that we have so many patients who are immunocompromised for various reasons, whether it's HIV or chemotherapy, whatever, we're seeing more and more primary toxo. This patient, a young man, presented to the emergency room. I was absolutely convinced it was ARN. I did PCR, expecting it to be positive for VZV or HSV. But my residents, unknown to me, also ordered a test for syphilis, and that's the one that turned out to be positive. So even syphilis can look like anything. And here's a patient with lymphoma, infiltrate, looking very much like a necrotizing retinitis, and of course a purchase type of retinopathy. And here are two cases of HSV2 where it looks more like a retinal vasculitis with very little necrotizing retinitis. And so we have to be suspicious of ARN in patients that do not absolutely have the characteristic necrotizing retinitis. And in one of my patients, the PCR was negative, and the trick here was to stick with your guns and repeat it in a couple of days. And here's a more classic acute retinal necrosis that we would recognize from, in this case, VZV. And here's another patient who had VZV that had been treated and the retina detached. And you can see that this is under silicone oil with a buckling effect in the periphery, and we're able to save his vision. Here's a patient that came in with EBV, and this was post-op. You can see the buckle under oil with the necrotizing retinitis. And I thought for sure this was just simply ARN. The PCR turned out to be positive for EBV, but what was interesting is when we did the surgery, the nurse anesthetist pointed out that the tongue was white, which made me think, well, maybe this was Candida. And we called the infectious disease specialist, and he said, no, this is hairy leukoplakia, and it's absolutely classic for EBV. So we're always learning. So we know a lot about acute retinal necrosis. It's a pan-uveitis. The incidence is somewhat rare, 0.5 to 0.6 new cases per million. The visual outcomes are often poor. 25 to 75% of eyes have vision worse than 2200. Retinal detachment rates average around 50%. VZV is more common. EBV is rare. Patients are usually immunocompetent, although the VZV patients tend to be older and perhaps have immunosenescence, as I discussed yesterday, that we're all acquiring. And some studies suggest the outcomes for VZV and HSV, and as well as the treatments, are very similar, and this is, I will disagree and show you why. So VZV tends to be in an older age group. They may have a history of shingles. HSV 1 and 2 tend to be in a younger age group, and they often have a history of neonatal herpes. They both present with acute uveitis, redness, pain, conjunctival injection, KP, AC reaction, endovitritis, and often a retinal vasculitis with the classic necrotizing retinitis. The clinical pearl here, and in America where we worry about lawsuits and malpractice, anytime a patient presents with iritis, anterior uveitis, you must dilate them, and you must look for necrotizing retinitis or sarcoidosis or any other posterior fundus condition that can also present with an anterior uveitis. And in fact, most of the lawsuits regarding ARN are due to delayed diagnosis because the eye was not dilated. The diagnosis is based on history and clinical exam, and we're very fortunate in our institution. We run PCR for VZV, HSV, CMV, and toxo on a daily basis. And again, if the PCR is negative, but your clinical suspicion is still very high, you can always repeat the test. So before we even get the results of the PCR back, I think this is one of our true ophthalmic emergencies, that ARN can progress somewhat quickly. PORN, it seems to progress minute by minute, but ARN is probably more like 12 hours by 12 hours. But if I'm very suspicious, I will treat with an intravitreal injection of foscarnet most commonly, and I will begin IV acyclovir. Now, it's been shown that oral valacyclovir is equivalent to IV acyclovir for treatment, but I like to bring the patient in the hospital because I think I get better compliance. Sometimes patients have difficulty getting valacyclovir. So we did a study, and we wanted to look at our patients who had positive PCR ARN, and it was a retrospective series, and we collected a lot of data, and so all the patients were treated with 10 days of IV acyclovir, and then they were switched to valcyclovir for a minimum of 3 months to reduce recurrence or spread to the fellow eye. And I use foscarnet because I don't have to dilute it. I can take it right out of the IV bottle for intravitreal use, and I give an injection every 48 to 72 hours for 3 or 4 injections until I see improvement. 2 of the eyes received intravenous cidofovir because in my experience, and I'll show you the data, that HSV is a worse candidate for ARN, and I think cidofovir, in my experience, works better, although it has its own risks, such as renal failure and rarely uveitis. You can see that we had about 8 cases of VZV and 12 of HSV. You can see the age range, that the HSV are definitely younger patients, where VZV tend to be older patients. And looking at the retinal detachment rate, you can see that out of the 8 patients, 75% of them with the HSV2 had detachments. And of those, 50% went to no light perception. So very, very telling in my experience that HSV2 is a much worse disease than ARN, which of the ARN category, and therefore that's why I've now been considering first step of cidofovir if it's possible. And you can see the visual outcomes. So in conclusion, the mean age for HSV2 was much younger than that of VZV. HSV2 ARN had a higher rate of retinal detachment despite similar treatment protocols. The final visual acuity was worse in the HSV2 group when compared to VZV. And in cases of intractable ARN, cidofovir may be a consideration in spite of its known complications and toxicities. Thank you.
Yeah, thank you, Andy, for this wonderful talk. I'll request Babulal to be please ready. Maybe we'll have a couple of questions while... any comment, Gopal? Mallika?
Yes, so we now use intravitreal ganciclovir high dose, 6 mg or 5 mg, so though you can give it just once a week instead of giving 2 mg every 2-3 days. So I think that's an improvement. Number of injections can be reduced, intravitreal.
So, topic for Debulal is very specific, very, very specific. And what is the role of brolucimab today? Because there have been controversies, people have hesitancy in shifting. Yeah, please.
Thank you, sir. I'd like to thank our teacher, Lalit Verma, sir, for having me here this morning. Very good morning to all of you. I'll be speaking on brolucizumab. Where does it stand today, basically? So this is going to be the agenda. Well, the prognosis of retinal vascular diseases has changed following the advent of anti-VEGF, and this is something we know. And what it has done, actually, is there has been a reduction of the blindness due to retinal vascular disease. So today, what are the treatment options that are available? We have off-label bevacizumab, ranibizumab, aflibercept, and of course brolucizumab, which was approved a little while back. Pegaptanib, we don't use it much. So what is brolucizumab? Brolucizumab is one of its kind single-chain fragment antibody with a small molecular weight of 26 kilodaltons. And because of the small molecular size, it is supposed to have deeper penetration into the retina and the choroid, faster onset of action, and greater molar dosing is possible, and also lower systemic concentration. So the approval came through after the Hawk and Harrier trials. And what we see here is that there isn't much difference when it comes to the visual acuity part of it with aflibercept. However, when you look at the anatomical structures, then of course you find that there's a difference. Brolucizumab achieved superior reductions in CST from baseline to week 16 and 48, and this difference was reaffirmed at week 96. Now, a comparison of the therapeutic response between brolucizumab and aflibercept in the Hawk and Harrier trials using deep learning-based OCT analysis showed that there was extensive decrease in IRF following the first dose. There was superior SRF resolution with brolucizumab. And one thing that was noted with aflibercept was the sawtoothing that was not there with brolucizumab. You also had more pronounced PED resolution with brolucizumab. So increased fluid resolution, is it important? Well, if we go back to CAT and IVAN and compare it with Hawk and Harrier, we have a similar story. If you have, more CST variation, you have poorer vision. So in Hawk and Harrier, in patients that were almost always dry or always dry, you had, these patients having lower CSFT variations. And these were the patients who had longer fluid-free intervals, had ultimately better visual acuity gains. Now, there has been a lot of talk about the IOI. So there was a safety review committee which classified and looked into the IOIs, and they found 49 cases, of which there were 44 of observations of interest, out of which 14 were IOI alone, 11 with IOI and retinal vasculitis, and 19 with IOI, retinal vasculitis, and retinal vascular occlusion. And
can we come to the topic per se rather than, you see, what is your impression, what is the role of Retina today?
Right.
So that, you know, we have a clear answer. This knowledge can be Googled from any time.
So, yes. So we'll move forward. And so basically,
the reason this topic was there because we are all familiar that IOI and vascular block conclusion is the bottleneck.
Right.
Why it is not getting so much importance.
Right. So basically, inflammation has been found to be there in other anti-VEGFs also, and there has been reports of racial and genetic differences with different anti-VEGFs and other medications. And based on our preliminary results of our studies, what has been seen is that in the Indian context, the number of IOI has been less. Now, the other important thing is that if you look at the Merlin study, which was stopped in between, what actually happened was that in this study, they were evaluating recalcitrant NAMD, and they had 4 weekly injections of brolucizumab and aflibercept. And as you can see, 9.3% was the IOI with brolucizumab and 4.45% with aflibercept. So what it ultimately meant actually was that a 4-weekly regimen with brolucizumab or maybe aflibercept was not necessary. So if you look at the real-world data from the Western world, with the IRIS and the Komodo providing us with the largest set of data, the incidence was 2.4%. Moving on to the Indian experience, according to these publications that we've had, we first published the Braille study where we actually had 94 eyes. This was an initial study. And what we found was that the durability was good. It was 10.2 weeks. And the visual acuity improvement was significant across the full cohort, so also the central subfield thickness. But what was most interesting was that besides the improvement in the fluid characteristics, the only adverse event that we recorded in this series was an RP rip, which we went on to publish, but there was significantly no inflammation in this series. So just to show a case example, this is a naive eye which received brolucizumab, and as you can see, after 1 injection, this is 1 week post the injection, the shram started melting up. There was this improvement in the CNVM complex, and this is at 12 weeks after 1 injection. And we repeated a second injection at this point in time because there was this hemorrhage that came up. And this is after 24 weeks of the second injection. So what happened post the Braille was that the patient was on a 12-weekly regimen, although we followed her up every 4 weeks. And she has, in 1.5 years, received 7 injections. The vision is still good, and there's hardly any fluid now. So we've also experienced brolucizumab in PCV. Again, it was the same story. Visual acuity improvement was good. It was statistically improvement. A lot of these patients actually went on to gain visual acuity. And actually, again, if you see that the disease activity results from the PCV study, 43% had no disease activity, that is no SRF or IRF at the last follow-up. Again, in this PCV subset, which we had a follow-up of 27, mean follow-up of 27 weeks, again, there was no IOI that was noted. And both of these were multi-center studies. We have little experience with the brolucizumab in submacular hemorrhage, and we used RTPA with C3F8 gas injection, and it seems to work well. Again, no inflammation. Looking ahead, brolucizumab in DME, the FDA has approved recently, just a couple of days back, brolucizumab for DME, and we were part of the KITE study. Again, similar visual acuity improvement. But what was interesting here is that 50% or more of these patients could be maintained on a Q12 weekly dosing regimen, which is important in the sense that these patients with diabetic macular edema could actually go on for a longer period of injection-free interval. So if you look at the KITE and Kestrel safety data, so what has happened here is that the KITE is basically this part of the study was mostly done in Asia and had a lot of patients from India also, and we were also part of this. So if you see the IOI rates were 1.7% for both brolucizumab and aflibercept, as opposed to Kestrel, where it was 4.7% for 3 mg, and 6 mg it was 3.7% compared to aflibercept, 0.5%. So again, there is this question of racial differences or genetic differences being part of the issue. What has been the Indian real-world experience in DME? Well, we've published 2 small series, and we've seen that
we need to summarize, please. Time is not on our side.
Yes, sir.
Yeah.
Yes, sir. So this is the last slide. So basically, it exhibited good visual acuity outcomes lasting up to 16 weeks and good anatomical improvement persisting up to 12 weeks, followed by early recurrence of fluid at 16 weeks. So the decision not to initiate a new drug is heavily influenced by who says what, but the decision to adopt a new drug is clinched by subsequent personal experience. Thank you for your kind attention.
Thank you, Devilal. I am still looking for that answer. Where are we today in brolucizumab?
So basically, sir, as far as IOI is concerned, so we've used 1100 vials at Disha, and as of now, we have 4 cases of inflammation. And all of these have been managed without vitrectomy. We've used topical and oral steroids. So that's one. And beyond the full Indian data, I'm not aware of how many, but what I hear is around 50 IOIs have been reported across the country, and probably around 10,000–11,000 injections.
Okay, we'll talk about it. Let's hear Dr. Sangeet Mistal about some situations of exudative RD.
Good morning, everyone, and thanks a lot, Dr. Lalit, for including me in this Retina Symposium. So I'll skip these basic slides, but situations generally, any pathological condition is potentially capable of violating the integrity of blood retinal barrier and cause exudative RD. The spectrum of associated diseases is so wide, ranging from isolated ocular conditions to multi-system disorders. And our approach to the treatment of an exudative RD patient, a thorough ocular and medical history is required. Though we must keep in mind that exudative retinal detachment may sometimes be a primary presentation of a systemic disease. And a complete ophthalmic examination, including indirect ophthalmoscopy with scleral depression to rule out any retinal breaks and the presence of regma, to rule out the regmatogenous component also in an exudative retinal detachment is required. Then ophthalmic imaging, thorough ophthalmic imaging, including the FFA, the ICG, OCT, B-scan, the UBM to get to the real cause of exudative retinal detachment. Physical examination, whatever we can do, we should do, but otherwise we should get a good physical examination done by a medical specialist or by a physician to rule out any systemic association of the exudative retinal detachment. And selective systemic investigations may be needed, like blood tests, the X-rays, the CT scan, or the MRI in some cases. The treatment of exudative RD depends on what the clinical situation is. It may be pharmacotherapy in the form of systemic, topical, or intravitreal medications, the laser or cryo, sometimes radiotherapy. PDT right now is not available in India, but earlier it was one of the treatment mainstays in ocular tumors leading to exudative RD, and sometimes when you are pushed to the wall, and the last choice, surgery might be considered in some of those cases. Coming to a few cases, a few situations, this inflammatory, like in this 18 years old female who had sudden decrease of vision for 7 days, gave a history of mild pain off and on, and best corrected vision was 6/12. And there was a small nodular yellowish nodule present just superior to the fovea with the surrounding subretinal fluid, and she was mistakenly diagnosed as a central serous retinopathy elsewhere. But when she came to us with the OCT, you see just there is one factor in the OCT which I'd like to point out is this: the contour is not normal. The contour of the OCT is raised on one of the sides, and this sometimes gives us a pointer that this is not a simple CSR case. It is something to do which is posterior to the retina. So this made us suspicious. We ordered a few more investigations. The FFA was very inconclusive. The ICG showed hyposenescence lesions, which remains so in the later phases. The investigations, they were almost, all these investigations were normal. But when we did a B scan here, so here highlighting the importance of B scan, there was a small hypoechoic shadow just behind the sclera in the B scan, and this there was on an MRI. Then we got an MRI done, and we saw a hypoechoic shadow posterior to the sclera in both the T1 and T2 weighted images, and this has been described as a classical sign of posterior scleritis in a study which was conducted by Dr. JB and myself while I was a fellow in Shankar Nethalaya, and this sign now guided us. We diagnosed this patient as a nodular posterior scleritis. We put her on oral steroids accompanied by immunosuppressants, And 2 months post-treatment, the SRF has resolved, and her vision had improved to 6/6. So another one of the most important conditions which may present as exudative RD, the inflammatory conditions, is the VKH. You have to keep in mind I think the first thing that you should come into your mind when you see a patient of exudative RD is a VKH syndrome. So going further to infectious situations, sometimes the acute retinal necrosis can also present as exudative RD, such as in this case. Though you may see this necrotic retina in the periphery, this patient was diagnosed to have herpes, and he was treated with oral valcyclovir, and 3 weeks later, all the lesions were absorbed, and the exudative detachment has disappeared. Another common condition is a tuberculoma, which may be seen. You can see this is a similar situation which was there in the first case as was in posterior scleritis, but there was a difference. There was on FFA, you can see a stippling hyperfluorescence in this lesion. And on OCT, again, you see that the contour is changed. The choroid is lifting the retina up. And this is one thing which helps you to distinguish that this is not CSR. Because nowadays, in general ophthalmology, almost everybody is having an OCT, and most of the times, the patients presenting with a small amount of serous detachment are diagnosed as CSR and put on observation. But we have to keep in mind that there could be something else below. So in this patient also, we did investigations. There was all her tubercular investigations were positive, and her mediastinal lymph nodes were enlarged. So we put her on ATT, and you see after a few days, after a few months, the whole of the lesions had resolved, and the vision has again improved to 6/6. So this was another patient, 59 years male. He was diagnosed elsewhere again on CSR and put on conservative management. But again, you see the contour on one side is lifted. And the fundus photo revealed a small mass lesion superior to the superior temporal arcade. And this mass lesion, again, we were able to diagnose it as a choroidal hemangioma. This patient underwent photodynamic therapy, and again, 1 week post-PDT and 6 months post-PDT, the choroidal hemangioma has regressed, and the vision has improved to 6/9. So this is a patient of capillary hemangioma, just juxtapapillary capillary hemangioma, again presenting with an exudative RD. And this patient again was treated with photodynamic therapy. We just modified the photodynamic therapy in this patient. Again, you see after treatment, the tumor has regressed and the exudative RD has disappeared. The patient is now able to see 6/36 after this. So some of the vascular, even hypertension can present as an exudative retinal detachment. You should keep in mind the signs of hypertension, the cotton wool spots, the retinal nerve fiber layer hemorrhages. And this was a 9-year-old female. She showed decrease of vision for 15 days and was diagnosed as choroiditis elsewhere and was on steroids. Nobody thought, because the child's age was not very suggestive of hypertension, but nobody thought of that. But when we did a FFA in this patient, you see there is one typical sign on FFA which suggested that it was hypertensive retinopathy. There were focal intraretinal periarterial transudates, and this sign has been described by Dr. Stone Singh Hare in one of his papers. We diagnosed that this patient was a hypertensive, and we checked her blood pressure, which was markedly raised. She was sent to a physician. She was diagnosed to have pheochromocytoma, and she was treated for that. And her retinal problem also resolved after the treatment of the primary tumor. So the some vascular conditions like Coates, I'll come to that later, or some degenerative conditions like PEHCR can also present as exudative retinal detachments, and the treatment again varies in these type of patients. You may have to do a peripheral laser or cryo, or sometimes it's self-resolution can be present. Sometimes even CSR can present as an exudative RD, like you see in this eye, there's massive exudation of fluid inferiorly going up. When we did a FFA, there were multiple leaks just adjacent to the fovea. We did laser, and 1 month post-laser, there was total absorption of this fluid. So just coming, this is the surgery, as I told, is the last approach to exudative RD. Just I'll show only 1 or 2 videos because of the shortness of time. Here, so you sometimes have to do a cut down in these patients. You make a sclerotomy here using a blade, and then you go in with a needle, and the fluid comes out. You have to take care, you have to remove most of this fluid. You can take this fluid into a syringe also if you want, for culture or for other investigations. And ultimately you suture this sclerotomy, because sometimes if it is a malignant lesion, you should not leave it open, this sclerotomy. So you suture this sclerotomy at the end of the surgery. Or what I generally nowadays do is I use IV catheter to drain out these exudative detachments. So I'm just taking a 26 gauge intravenous catheter. I insert it as far as away from the limbus as possible. I see when the tip is inside the subretinal space, I just move the plastic tip inside and remove the metallic stellate out. And you see the fluid is coming out. And this can again be connected to your extrusion pump. And you can foot control the amount of fluid that you want to take out. I think I'm short of time now. I should end here rather than continue. Thank you, sir.
For excellent collection of patients, and I think the applause says it all. I think all of us gained by your presentation. And since time is not on our side, we'll thank all the speakers, our guest speaker, Dr. Andy, and all the panelists for making significant contributions for this symposium. Thanks, everybody. And thank you, audience. Thank you.
Thank you.
Yeah, we have a group picture actually. Customary.